Hello, everyone, and thank you for attending today's webinar, What 2018 Taught Us About Social Determinants of Health. Today's webinar is hosted by the healthcare group at LexisNexis Risk Solutions. My name is Lisi Feliciano, and I will be moderating today's webinar. Before we begin, I'd like to cover a few housekeeping items. At the bottom of your screen are multiple application widgets that you can use. All of these widgets are resizable and movable, so feel free to move them around and get the most out of your desktop space. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit them through the Q&A widget. I encourage everyone to submit their questions as the content is being presented, and we will leave the last 5 to 10 minutes to answer questions. Be assured that we are capturing everyone's questions, and if we run out of time, we will respond via email. Additional materials are also available in the Resource Center. We've posted a few white papers and case studies and informational sheets, so we encourage you to download those resources that you might find helpful. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause any issues. Webinars are bandwidth intensive, so closing those browser tabs will help. And of course, if you have any problems, you can submit a question and our platform technicians will reach out and try to help you resolve that. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters clearly. Some networks cause slides to advance more slowly than others, so logging off of your VPN is recommended. If your slides are behind, pushing F5 on your keyboard will refresh the page. We anticipate potentially a 10 to 20 second delay in transitions of slides, so bear that in mind as the presenters are running through their content. An on-demand version of the webcast will be available and sent to your inbox in about 24 hours, so look out for that. With that, I'd like to now introduce our presenters. With us today from LexisNexis Risk Solutions is Erin Benson, Director of Market Planning. Erin is the Director of Market Planning for the healthcare group, and she focuses on the development and execution of strategic planning for all identity management and social determinants of health solutions. She came to LexisNexis from Deloitte Consulting, and she is paramount in assisting customers in operationalizing identity solutions and particularly social determinants of health. Also with us today is Eric McCulley, Director of Strategic Solutions. Eric is the Director of Strategic Solution Consultants and leads a team of identity solution architects. This group has deep subject matter expertise specific to member and patient identity solutions, including social determinants of health. Mr. McCulley started his healthcare career as a nurse administrator in cardiology, endocrinology, and intensive care, and his experience goes well beyond helping our customers to understand the value of these data insights and how to leverage them to improve patient outcomes. And with that, I will turn it over to Erin.
Thank you, Lisi, and welcome everyone. We at LexisNexis would like to thank you all for joining us today. The evolution of social determinants of health in the market has been an exciting one, and we look forward to discussing what 2018 has taught us. Social determinants of health continue to provide healthcare organizations with opportunities to adopt new and innovative strategies in achieving organizational quality and then subsequently financial goals. While we recap 2018 today, we hope that today's session will lead to continued conversations and will provide our direct contact information at the end. This afternoon, we'll examine what is needed to deliver success with social determinants of health. This will include recapping some of the headlines related to social determinants of health and debunking common myths. Our goal is to reveal the truth about requiring correlation to health outcomes and what data is required for successfully improving the health of patients and members. Social determinants of health innovation can impact quality goals while reducing costs and improving member experience. So to illustrate this, we'll look at examples of ways social determinants can enhance predictions as well as impact care coordination. We'll also address the importance of identifying combinations of socioeconomic factors in assessing member risk. A couple scenarios will help bring this discussion to life so you can see how socioeconomic data can enhance your workflows. Social determinants of health, which includes information on relatives and associates, assets, trends over time, neighborhood and household characteristics, and more, can be utilized to improve care management and risk stratification activities, with the ultimate goal being to improve member and patient health. Social determinants of health is certainly a popular topic in the market today, and with good reason. We're so used to managing our health around social determinants that we aren't even consciously aware of the impact they have. I know I was surprised to learn that 1 in 3 deaths in the U.S. annually are related to social factors. The impact is significant. We like to say that social determinants of health are the X factor needed to identify not only who needs help, but also how to help them achieve optimal results. What we mean by this is that what you can learn from claims data alone is not a comprehensive picture of the individual. The environment in which a person lives impacts their likelihood to develop health conditions, as well as their likelihood to effectively manage those conditions. Care recommendations need to be a good fit for a member's environment and not just their medical condition. If the recommendations won't work within the person's physical environment, aren't affordable or conveniently located, or provided in a way that is hard for the member to understand, they're not going to be effective at improving health. Studies such as the ones that you see on this slide support that. But the news has reported a variety of perspectives on social determinants of health, so we want to look at some of those headlines now. You'll see here that we have 5 different articles that are listed, and you can follow the links at the end if you want to get more information. But we'll recap some of the key takeaways from these and what that says about where social determinants are headed. In the first article, experts urge more focus on social determinants of health. Experts who worked at organizations such as UT Austin, Intermountain Health, and the Department of Health and Human Services emphasize the importance of social determinants of health in impacting health outcomes. And they encourage more focus on awareness programs, providing assistance to address social determinants, and aligning health and government systems to incentivize this assistance. The second article emphasizes similar themes, with Humana announcing plans to invest nearly $7 million in 9 local organizations that are committed to addressing social determinants of health. These organizations include the San Antonio Food Bank, the AARP Foundation in Florida's Broward County, and more, all chosen with the goal of improving population health in those chosen communities. The third article emphasizes the need to be able to collect, standardize, and store that data in meaningful ways to be able to identify tangible and actionable insights. The fourth article raises some concerns that we hear from consumers, which is that social determinants insights could have unintended consequences if they're used to deny coverage to certain groups or individuals. We at LexisNexis have taken steps to see that our data is only used to help individuals improve health outcomes and not to set rates or deny coverage. Eric will talk more to that in a little while. Finally, the last article we highlight is about guidance from Health and Human Services. The point from this article that stood out to me as unique was that the Health and Human Services Secretary warned against limiting the focus of social determinants of health assistance to 1 or 2 social determinants, to the exclusion of others. They encouraged healthcare organizations to connect individuals to the specific services that meet their unique situations, rather than offering a one-size-fits-all approach. Across all of these articles and the media attention we've seen in general around social determinants of health in 2018, there are 3 common trends. First, the industry sees value and understands that investments in this area are important. Second, there's still a need for education on what social determinants of health is and is not in order to make it meaningful. And third, there's the realization that to impact social determinants of health, all stakeholders involved in the delivery and coordination of care must be aligned. My conversations this year with healthcare organizations have echoed these trends. It's clear to me that the value of social determinants is becoming more recognized, but defining what data provides insight into social determinants and how it can be used is far less clear. One other viewpoint we wanted to provide is the consumer side of the equation. Consumers are indicating that they want more collaboration between healthcare organizations and their communities. A PwC Health Research Institute consumer survey illustrates this, with the majority of consumers saying that it is important to them that hospitals, health plans, and employers have partnerships with their local community resources to help them improve their health. Now that we've explored various viewpoints and considerations around social determinants being explored in the market this year, I'm going to turn it over to Eric to separate myth from truth about social determinants data and explain our perspective on where social determinants should be used to improve health outcomes.
Thank you, Erin. In order to shed more light, I do want to reiterate the importance of social determinants of health and improving health outcomes. And a good place to start, I think, is level setting on some pretty common myths that are circulating around social determinants of health data. To maximize value of addressing social determinants of health, it is first important to know what specific data can provide meaningful and impactable insights. So let's look at these myths and truths about social determinants of health now in order to establish a better baseline. The first myth is that socioeconomic data is just more noise in an already data-saturated environment. While it's true that in the age of big data, it is easy to become overwhelmed, socioeconomic data is proving its importance and its clinical significance and is rising as a top priority for many organizations. You have probably all seen studies that illustrate that medical care determines only 20% of overall impactable health, while social, economic, and environmental factors determine greater than 50% of what is overall and impactable health. So to effectively achieve better health outcomes, we simply can't afford to be without the very data that gives us these insights to impact what we can change. Our experiences across the healthcare industry delivery system really proves that the more accurate data that we have, the more effective and efficient we can be in our risk assessment and ultimately our care delivery. Innovative payers across the country are continuing to evolve ways to incorporate socioeconomic data into their workflows, into their predictive models, and into their care management programs in order to have a meaningful impact. So intuitively, more accurately identifying these impactable high-risk members can help all of healthcare become more effective and more efficient in appropriating the best resources to achieve the best possible outcomes. The second myth about SCOH is that all data about a person and their life outside of their medical claims relates to their social determinants of health. The truth is that while some social data may be useful in certain capacities, not all data on a person is a social determinant of health. To put it bluntly, if the data isn't or cannot be correlated to significant health outcomes, it's just social data. There are limited ways of receiving individual patient-level data. Most sources simply survey data at a demographic level or survey data or use marketing data, and much of that is limited in its capacity for clinical utilization. So the potential for improving predictive power or identifying hidden risks is pretty limited. A key to sourcing significant SCOH data is that that data is continually updated, is provided in a consistent and ingestible format, and is based on reliable sources such as public records. And perhaps most important is that these data have been clinically validated to correlate to specific healthcare outcomes. Clinically validating attributes is critical to successful predictive analytics. In our analysis to date, our data science team has validated 442 clinically validated social determinant attributes that correlate with key health outcomes like readmission, medication adherence, hospitalizations, overall health costs, and even motivation to engage in one's own healthcare. Understanding the power of specific individual level attributes can greatly enhance the predictive power so you can improve risk stratification as well as your clinical care intervention strategies. The third myth is that examining only individual socioeconomic attributes would allow for accurate predictions about a member's overall health risk. Even though social and economic factors account for a great percentage of impactable risk, a comprehensive clinical and social determinant profile is ideal. The truth is, focusing in on individual attributes rather than a combined picture can be misleading. The results can look very, very different. When predicting risk and personalizing care management, it's really critical to view a person holistically across multiple categories of social determinants, ranging from their social and community context, their economic stability, and their education are all important considerations. And any of these attributes on their own might simply not be enough to develop an accurate risk profile. But by using a combination of clinically validated attributes and healthcare data, a more complete picture can emerge. For example, low income can often correlate with poor health outcomes. But it's important to understand that there could be additional knowledge that could impact the way you would approach that particular patient or member. For example, if a patient has moved greater than 3 times in the last 12 months, or their nearest first-degree living relative is greater than 50 miles away, could add critical insights to help shape the predictive risk and provide a greater platform or more specificity to create a better clinical care intervention strategy. The fourth myth is probably the one that I hear most often, and that is aggregated data at the zip code or census level can be used to extrapolate social determinants at a geographic level and apply those to personalized care for a member. For market expansion and resource allocation decisions, looking at an aggregate level of data can in fact be useful. But for risk stratification and personalizing care management, hundreds of attributes should be considered. Within a single zip code, it's really not unusual to see a significant variation of income levels, crime rates, and other factors that would impact an individual's neighborhood and built environment. Think about a major city like Atlanta, where Aaron and I are presenting to you today, and the amount of change that you might see just by walking a few city blocks. This is why it is so important to know an individual's specific address. Further focusing on zip code alone ignores the influences of education, economic stability, and social and community context. Acquiring data across various categories of social determinants at the individual member level allows care providers the most comprehensive view of their patients in order to create the most comprehensive and effective plan of care outreach. Finally, the last myth we will discuss is that social determinant of health data is only useful in combination with clinical data. Adding socioeconomic data to clinical data can help payers to personalize care and more accurately predict risk. However, even in the absence of clinical data, using only socioeconomic data has proven to be useful. It can more accurately predict risk based on total cost than traditional age and gender predictions alone, and is accurate and sometimes more accurate at predicting readmission risks than certain more traditionally used clinical data models. Even small lifts in accuracy over traditional predictions can lead to big impacts. Using socioeconomic scores to more accurately identify higher risk members who account for the majority of healthcare costs and proactively address their care based on those insights can lead to significant savings over traditional predictive models alone. The key takeaway from reviewing all of these myths is that socioeconomic data is a vital force for healthcare risk prediction and the improvement of care management. You will hear us continue to reinforce that we see this data being used for improving care, but I do want to dive a little deeper into our position on where we believe it is in the best interest of patients and members to use these critically important insights. As Aaron alluded to earlier, with these data insights come significant responsibility. And as the headlines Aaron recapped for us previously show, there are positive and negative ways for social determinants of health to be used. Our position is that social determinants of health should be used to help patients and members achieve healthier outcomes. There are really two ways in which we feel this is best exemplified. The first is utilizing social determinants of health attributes to be incorporated into existing claims-based predictive models in order to improve their predictive accuracy and in order to create new predictive models. As I mentioned, our data scientists have found hundreds of correlations between socioeconomic health attributes and actual health outcomes like total cost, hospitalizations, medication adherence, and emergency room utilization. So this is indeed a valuable and viable use of our data. The second related use is for care management purposes. And this is where we have seen SCOH be truly transformational. A specific best practice is to use social determinants of health to identify barriers to health and leverage those insights to help break down those barriers. These barriers can be things like educational disparities, address instability, social isolation, poverty, and neighborhoods with significant safety concerns. For example, a neighborhood safety concern could be that the high crime index leads to a fear to go outside, which contributes to a lack of exercise in the community. Lack of exercise, we all know, is correlated with worsening conditions around obesity and cardiovascular implications. In building models that identify health barriers, payers and healthcare delivery systems alike can inform clinical care stakeholders about the types of interventions that will be necessary to improve health outcomes. In the shift to fee-for-value, pay-for-performance, and shared risk delivery systems, the evidence is overwhelming that identifying social determinants that drive risk can have really meaningful clinical and community intervention strategies, and everyone can realize the benefits. And while there are tremendous possibilities to do good with social determinants of health insights, we do not allow our data to be used for rate setting, marketing, or coverage decisions that could lead to denial of services. We take a firm position that social determinants should be used solely to help patients and members improve upon their health outcomes. We hope by now you have started to conceptualize the many ways that SDOH can be integrated into your organization's workflows in order to produce value. Utilizing insights on social determinants of health, payers can more accurately surface members that require action and provide better care management by incorporating SDOH datasets. This leads to better qualitative and better financial outcomes. Back to you, Erin.
Thanks, Eric. Now that we've looked at some of the myths surrounding social determinants of health data and we've started to discuss some of the use cases, I want to dig into the pitfalls the industry has encountered so far in the pursuit to find value in using these insights, and what is needed to overcome some of those previous challenges to successfully generate the positive value that you talked about. While the phrase social determinants of health is in vogue, attempts to marry claims and enrollment data with outside member intelligence have gone on for some time. First-generation attempts focused on using community data, which provided some insight around a member's neighborhood and community, but completely missed all the other categories of social determinants of health, which really require member-level information. Even within the community data, there were challenges. As you mentioned before, while some neighborhoods are homogeneous and assumptions can be inferred, other neighborhoods, such as some urban areas, have luxury condos and Section 8 housing next door to each other. This makes drawing any useful information out of them challenging. This led to the second-generation attempts, which was pulling non-clinical data, but looking at evaluating data from sources that could provide that member-level detail. That data wasn't built for healthcare use cases, however, so it was a limited use. These data sets often came from marketing companies and consumer data companies, and while they were useful for their original marketing use case, their match and fill rates tended to fluctuate wildly, and the data wasn't as reliable as regulated data, which made it difficult to use in building predictive models. Additionally, organizations found that utilizing marketing data as a substitute for social determinants data meant their analytics teams had to spend a lot of time simply examining the data and deciding which, if any of it, could be used in modeling. As Eric pointed out to us earlier, not all data about a person is a social determinant of health. If we're going to cross from non-clinical data being an interesting idea to being a valuable resource, we'll need to work with a data set that has been clinically validated and addresses all categories of social determinants at the member level. These early attempts at generating value from social determinants of health taught us two critical lessons. First, the quality of the data that provides those insights matters. Data to be used in any social determinants of health exercise must come from extensive sources covering marketing, public records, credit, and consumer data that can paint a comprehensive picture and provide insights into a member's economic stability, their educational background, their neighborhood and built environment, and their social and community context. It should provide information about the individual and their surrounding network of support, such as their relatives and household members. Most importantly, as I've mentioned, every element should already be proven to correlate to health risk so that healthcare organizations can spend their time building meaningful predictive models and care management programs and not wading through data dumps to find relevant data. Second, we've learned that analytics groups and care management groups within organizations need to work together to integrate social determinants of health insights into workflows in order to achieve the value. Targeted action must be taken for health to improve. So simply put, we need to be innovative on, first, what we model, and then second, how we present that information to care management teams. We've summarized this into a three-step process. First, social determinants of health predictive models can be used to identify members and patients who face health barriers to improving and maintaining their health. Second, those factors can then be turned into scores that can be used to understand the severity of that risk for each member and prioritize outreach. Third, care management teams can be provided with insights about how to approach individuals based on those individual social determinants' needs and their relative risk. Tailored, prioritized outreach efforts based on individual need that address the whole person and not just their medical condition are how health outcomes can improve, which can help to manage organizational costs. Next, we'll take a deeper look at some of those social determinants categories and how they can be applied to improve care management. So let's look at some of these examples of key social determinants of health and why they're important. Address stability and economic health are related social determinants of health. There is a high correlation between members with a high number of addresses in the last 60 months and use of the ER. This makes sense because if you're worried about having a roof over your head, you're probably not focused on your health, or you might not have the financial resources to visit a primary care provider. Social isolation can be predicted based on attributes related to proximity to nearest relatives and associates, marital status, number of people in the household, and more. Earlier this year, I found a news story fascinating from the UK where they had appointed a minister for loneliness. This seems like such a unique concept, but the reality is that social isolation and loneliness are correlated to negative health outcomes, putting the individual at greater risk of cardiovascular disease, dementia, depression, and anxiety as examples. So imagine the impact that could be had by getting those individuals into support groups or arranging for more frequent follow-up calls. Information on education can provide insights into health literacy levels and incomplete perceptions of health. This may indicate the need for more education or differently designed education, such as videos, to help members know how to take care of their own health. Each of these social determinants and more correlate to health outcomes, and we'll look at another couple examples. This example is one that Eric mentioned. At LexisNexis, we're able to identify how close a member's nearest relative or associate lives to them. This is important because it provides insight into their social and community context. Our data scientists found that members who have relatives or associates that live with less than 25 miles away are more likely to adhere to their medications. There is a drop-off when their nearest relative is more than 25 miles away. Knowing this, more education could be provided to the member on their medications, or programs could be put in place to have those medications delivered to their homes on a regular basis to improve adherence. Another example is related to economic stability. Our data scientists found a correlation between readmission to the hospital within 30 days of an inpatient hospital stay and the sum of tax-assessed values for all properties currently owned by that member. The correlation showed that individuals of the same age who have higher average property values are less likely to be readmitted to the hospital within 30 days than those who have lower average property values. These are just two examples among hundreds of ways that socioeconomic data can provide important insights for predictive analytics. Eric will now share a scenario that illustrates how understanding social determinants about individuals can be used to tailor care and achieve value.
Thanks, Erin. To generate value, you need to deploy models not only for risk stratification, but also models that identify the health barriers that, unaddressed, would lead to missed opportunities to improve the member's health. Let's look at the story of Bill and Larry. If we only look at claims and enrollment information, Larry and Bill look very similar and would probably be treated the same way or placed in the same program using these traditional methods. However, our experience does tell us that we see dramatically different results in health outcomes from Larry and Bill. Well, why is that? If we can supplement our knowledge of Larry and Bill by building models that uncover health barriers, we can begin to understand if there are differences between Bill and Larry that we would need to account for in building our specific intervention plans. If you recall, our first learning was to make sure we have member-level data that addresses all 5 categories of social determinants of health and is already correlated at health risk, right? So if you take that and build models that identify health barriers, you could learn that Larry and Bill look very, very different. The result? Now we know that Larry has significantly more risk than Bill, and yet the picture we had solely from claims information would have steered us down a different path. What you see from left to right in this next slide is a representative of a severity index a care management team might use to stratify your at-risk population. Prior to our innovation, this is how care management would initially see Larry and Bill. Essentially, they may both be put in queue for an initial outbound call or letter and encouraged to take a health risk assessment. However, if we deploy models that identify social determinant health barriers for both Bill and Larry, care management can realize from the start that Bill represents little risk and can probably improve his outcomes with lighter touch points. Larry, however, represents a more severe risk and likely needs immediate assistance to prevent negative outcomes. So what are some examples of what we can do with this new information about Larry's significant health barriers? Well, we can leverage village or township resources or religious services and disease-specific programs. We can make arrangements with local transportation, taxis, and rideshare programs like Lyft and Uber. We can coordinate with Meals on Wheels or investigate other food delivery programs if they live in designated food deserts or do not have access to transportation to get the food that they need. Exercise can be arranged by local YMCA and Park District programs or by sending a physical therapist or other community resources to their homes. We might also consider arranging for medication delivery and discount programs for the more expensive drugs, given the financial implications we see. We can also create more customized materials written to address the multiple education levels and provide more phone outreach to those who might have a difficult time in understanding written instruction. There are other ways to help Larry too. If we know Larry's health barriers, we can begin right away to mitigate his severe health risk. Social determinant insights reveal the health barriers to discuss with the member, and then care management teams can collaborate with the member to determine the best plan of action. Erin has another example to share of data in action.
Thanks, Eric. In this next example, we're going to look at how predictive analytics based on social determinants can help to reduce readmissions to the hospital. In this scenario, we have 4 male patients admitted to the hospital with heart failure. Studies have shown that the average rate of readmission is 20% across conditions, but it increases for heart failure to 25%, meaning statistically at least one of these gentlemen will wind up back in the hospital within 30 days. But when they have the same age, the same gender, and the same condition, who is it likely to be and how can it be prevented? This is where social determinants come in. A readmission risk score can be applied that predicts the likelihood of each of these patients to be readmitted to the hospital within 30 days of discharge based on that individual's social determinants of health. The scores shown reflect the probability of each man being readmitted between 0 and 100%, with 100% being the highest possible risk of readmission. So as you can see here, Tony is the most likely at 78% to be readmitted to the hospital. Alex and Chris also have some social determinants challenges that raise their risk of being readmitted. So what this illustrates is that with only age and gender and medical data on individuals, we might be missing opportunities to intervene before a complication develops or worsens. Social determinants of health provide that view that would otherwise be hidden. Now, understanding each individual's level of risk, we can effectively prioritize resources to reach out to those patients, and this improves staff productivity and patient outcomes. A readmission score based on social determinants will improve staff productivity and resource allocation, but it can also help with personalizing care. The reason that social determinants have such an impact on these patients is because care recommendations need to be a good fit for the patient's environment and not just their medical condition. If we look at the attributes on these individuals, we start to see social determinants that can be addressed and risk drivers that can be raised to their care teams. Tony has had a significant decrease in income, he's sold his house, and he's moved 3 times over the last year. These are indicators of economic instability, so Tony's care team should ask questions to determine if Tony has a stable place to recuperate outside of the hospital, and if he might need financial assistance to help with follow-up care. As the highest risk individual, allocating resources to help Tony with his social determinants challenges would likely be a top priority. Alex, on the other hand, recently moved to a high-crime area and he doesn't own a car. If the hospital is located in Washington, D.C., we could reasonably assume Alex still has access to public transportation and pharmacies. But if he's in a hospital here in Atlanta, which is mostly a vehicle-driven transportation system, a care provider may want to discuss transportation and medication and food delivery options. Chris is showing only moderate risk. He does have someone over the age of 80 living with him, which may be an indicator that he is providing care support. So asking Chris questions about his household situation could lead to getting him connected with a support group or finding alternative care for him and his elderly household member while he recuperates. And then finally, Greg is not showing really any significant social determinants risk indicators. So best treatment practices for someone with his aging condition may be the most appropriate. So as we enter mid-December and the end of 2018 is in view, where are we as an industry? Today in this webinar, we've explored the benefits of social determinants of health and some of the challenges to achieving those benefits. We've learned that one of the key challenges is being able to incorporate socioeconomic data into predictive models and care management so that there's just so many ways of getting that socio data, and not ways are equal. Only certain data is actually useful in predicting and determining health, so it's really important that organizations look for the most useful data. It should be current, comprehensive, and longitudinal data that can be consistently linked to the individual members and the populations and provided in a standardized format. Utilizing public and proprietary records can provide that type of data, and we also recognize that not all data correlates to health outcomes. Organizations will want to look for that information that has already been validated against health outcomes and be prepared to validate that information through their own internal analytics groups if they are unable to find it. We believe looking for these aspects in socioeconomic data will best position organizations to achieve the most valuable outcomes. But, and here's the catch, only if that action is taken as a result of the data. We highly encourage the use of social determinants not only in predictive analytics to identify who is most at risk in a population, but also to address the individual member's socioeconomic needs. We saw examples of this with Bill and Larry, and also specific to readmission risk. We hope this has been insightful for all of you, and we would like to turn it back over to Lisi now to open up the session for questions.
Thank you, Erin. Thank you, Eric. So as a reminder, if anyone has questions, you can submit those using the Q&A widget as part of the platform. We do have a few questions that have come in, so we will start taking those as folks submit additional questions. First question, whose buy-in do we need in the organization to start a social determinants of health effort?
So this is Eric, and I think that's a really good question. I think the first part of that is dependent upon where in the workflow do you expect to see the data surface. So how you operationalize the data oftentimes has a great degree of influence on who you need in order to achieve buy-in. What we do know and what we have seen in our experience is that when these data are leveraged to create a more powerful risk stratification tool, there is an IT lift on the front end, and so those in your organization that are responsible for the technical implementation, as well as the statisticians, analysts, business analysts, predictive modelers that will need to work with the raw materials in order to build those models are also important stakeholders. What's interesting, though, and what I hope that you've all gleaned from this presentation is that the impact of leveraging these types of data is far-reaching across the entire organization. And oftentimes it's many people across various levels of the organization, from IT to clinical care to the healthcare professionals themselves at the point of care, that are making decisions around how best to leverage the data.
Thank you, Eric. We have another question. What SCOH costs are covered by Medicare Advantage plans or Medicaid?
That's a great question. And, you know, it's interesting, one of the articles that we cited in this, and what you'll see out there, is that that's changing. So Health and Human Services is really focused on trying to incorporate more of that into their plans going forward. And so we're going to continue to see social determinants more covered in the future. Right now, it's a lot of community partnerships that we're seeing. So it's, you know, as you saw with Humana, it's reaching out to Meals on Wheels or to the food banks or to the local communities and partnering to find ways to cover those resources. So we're seeing organizations get creative, but the government is definitely taking notice, and I expect to see some changes in policy and what costs will be covered going forward.
I would just add that from a reimbursement perspective, if you're not familiar with the ICD-10 Z codes, specifically those Z codes are specific to social determinants of health and various subcategories of those social determinants of health. So I think we'll continue to see the landscape shift a little bit around reimbursement across all lines of business as it relates to claims being adjudicated with these Z codes as part of that process.
Great, thank you. Another question that came in, does LexisNexis have the ability to add SCOH data to EHR?
Yeah, that's a great question. So we deliver our data in a way that is system agnostic, so you can either get it as a batch, I'm having trouble here with that one, like it's a tongue twister. Flat file delivery option, which you could then use to load that data into an EHR. We also have API and XML capabilities so that you could connect that in directly. So we really work across different types of systems that can provide data in different ways so that you could integrate it into your existing EHRs.
Great, thank you. Just a reminder, we still have time for questions, so feel free to submit them as we address a couple more that have come in. The next question, is there anything we should do before we start a social determinants of health initiative to make it more successful?
Well, I'll start, and then Aaron, I'll turn it over to you. I think the most important thing you can do is operate with the end in mind. So is the idea in incorporating social determinants of health to increase your predictive power on the front end of the healthcare continuum by way of stratification methodologies and predictive modeling? Or is it a little more direct and tied specific to healthcare barriers, for example, where you can perhaps more easily effectuate quality of care and more defined or more precise care interventions as a result of the insights that those data can glean?
I think that's a great point. I think what I would add is probably a little more on the tactical side, but what we've seen is that the organizations that go in and work with a third party or work with their patients to update their contact information have the best success, because a key part of social determinants is you have to be able to engage with your patients, and if you don't have accurate contact information or up-to-date contact information, or if your records are disorganized and you have, duplicate records in your systems or things like that, it's going to be really hard to reach out and provide effective care. So a lot of times we recommend by first cleaning up your records and getting updated contact information, and then getting the social determinants of health data so that you know how best to then help with their targeted care.
Great, thank you. The next question, I think you touched on it a little bit earlier. It's how are the insights available?
Yeah, so this is what I was referring to earlier. So it can be you guys are going to make me do the tongue twister again, the flat file delivery, or we can do it in real time with API, and it really just depends on your organization's needs and how quickly you want that. The other thing that we really encourage is regular and frequent updates, because people move constantly or their last names change, and every time there's a life event that occurs to your members, their social determinants have also altered, and so we recommend not only checking in one time on what social determinants are for a patient, but checking in regularly to make sure that you're always up to date on what might be impacting your patient at any given moment.
Thank you. So another question, is there a standard SCOH assessment tool, or one that you have found, that we have found at LexisNexis, captures the most pertinent information?
Well, I would start by saying I think the answer is no. I think that, as we alluded to earlier, there continues to be a need to educate the market around what are true determinants of health. And as our analytics continue to flesh out what those determinants are, we may start to see the evolution of standardized tools to help capture that. I do think the ICD-10 Z coding process is beginning to take aim at standardizing social determinants of health. We've seen social determinants of health as criteria for specific eligibility with Medicaid waivers. So I don't think we are standardized, but I do think we are getting more in alignment with all of those that are interested in defining these types of data.
Yeah, I agree, Eric. I think the other place that we've seen pushes for standardization have been around the types of questions that get asked in patient and member surveys. So I could see achieving some alignment around that, which is interesting to me, because I actually think that the better approach is to look at some of the data that you can get from public records and then tailor those questions to the individual so that you're not asking questions that aren't relevant to their situation. So my hope is that the industry will really focus on that personalized care. as well as looking at more standardized ways they can bring in SCOH data.
That's great. And that kind of leads to the next question, which is what is the best source of SCOH data? How does vendor data compare to U.S. Census and other publicly available information?
Yeah, that's a great question. So I'll take the second part first, which is the census data. It's not updated very frequently, so this goes to what I was saying before, which is it's not going to capture the life changes, and it's harder also to zero in on that member level information, which is really critical when you're tailoring care. Our perspective at Lexis is that the best source is one that you can get from public records data because it can be standardized, it can be consistently provided, and it tends to be the most reliable data because of the source that it's coming from. A lot of times when you're filling out those patient surveys, you may be in a hurry and you may rush through them and not be as complete as what you could get from public records data. I don't know, Eric, if you'd like to add anything.
Specific to the sources of data, the only thing that I would add is that it's very important to consider the breadth of sources with which your data sets are originating. There certainly are data sets available that are more financially slanted. And so those out-of-wallet public records data that give some perspective to some of the categories that both Aaron and I outlined in our presentation are, I think, an important consideration for the types of sources you would consider, or if you're looking at various vendors to contribute to your data repository, do those vendors have a breadth of sources that capture more than just out-of-wallet financial types of data?
Great, thank you. Again, if you have any questions, feel free to send them in. Another question here. How do we align with organizations across the healthcare spectrum to provide care?
Well, I'll take a first stab at this one. So I think that's a really salient question because ultimately it's about aligning, and it's about understanding that first, social implications contribute greatly to the ability of any healthcare provider or delivery system to optimize care. And so what we continue to try to do is define what quality metrics we're trying to achieve. I alluded to the persistent migration or evolution to a fee-for-value and pay-for-performance platform. One of the hardest things that, and coming from a healthcare background and being in healthcare for over 20 years, I can tell you is that at the end of the day, what we're all trying to do is effectuate behavioral change. And until we get alignment on the best opportunities to identify what those barriers are to behavioral change, we can't very well address them. So it is our hope that by bringing these types of insights to light and incorporating those into the workflows, whether they are in the modeling, predictive modeling stages, or more tactically embedded into the care management platforms, that these types of insights are helping drive that alignment.
Okay, thank you. Another question, how, as SCOH becomes more common in the space, how do we measure the outcomes?
Yeah, I think one of the key challenges around this is how do you know that you can attribute the success you're seeing to addressing social determinants versus the many other things that could be impacting that patient. And so I think we almost rely back on traditional science where you might need to take a control group and a new user group and do more traditional methods with a control group, and then with the new user group see if addressing some of their social determinants has a different impact. I think readmission risk is a good place to do that because within a 30-day window, you can see whether you've been successful or not in helping to reduce some of those readmissions. But some of what we're going to see in terms of measuring impact is going to happen over time because some of these are more longer term, like medication adherence and things like that, to measure. So that's why I would recommend taking some of the shorter term ones and looking for wins like the 30-day readmission reduction.
Thanks. Another question, any pitfalls with SCOH from early implementations that organizations should, who are looking to implement, should be aware of?
I would say that we've learned a lot as we've worked alongside our strategic partners. And one of the pitfalls is the standardization of data. I think you heard multiple times in the presentation that one of the quality criteria to consider in sourcing any data is the standardization of that data so it can most easily be ingested into the analytic workflows or into the clinical intervention workflows. And I think it's also important for the payer and or provider healthcare system to very narrowly define what are the social implications that they're trying to address. I think there's already an underlying understanding because of the familiarity with the communities that healthcare systems and payers are working within, that you can look at the set of data or sets of data and decide what's going to matter most and just start small rather than taking the old adage of throw everything into the data hopper, so to speak, into the EDW and see what our sophisticated machine learning environments can produce. Let's use some common sense around what we know the data tells us and start small and very tactical around that data.
Thank you. Another question, how does SCOH fit into the increasingly heightened sensitivity regarding personal privacy? What kind of change management is most effective?
Yeah, we get this question a lot. I think the key to understand is that any data that we provide to healthcare organizations or that they use are, under HIPAA considerations. They're also, in our case, regulated by the Gramm-Leach-Bliley Act and by other key regulations, and we only provide this data for care management use cases. So as you saw from that consumer survey, more and more patients and members are expecting that healthcare organizations be able to tie them to community resources. And I think as we have busier and busier lives, making that the most efficient is going to be something that's welcomed by patients as long as they feel like it is something that's only provided to their healthcare organizations to help with their health. I think the other key point that we often make and that Eric pointed out before is that we're not providing this data directly to your care provider. So it's not the person that the patient is interacting with that is going to get every one of these analytic attributes that we talked about. They're going to get health alerts. So it might be something like this person has a lack of transportation, and that's just going to give them the information they need to be able to have a conversation with the patient to be able to provide the best care. So the attributes are used by the analytics groups for modeling, but what is actually provided to a social worker, a care provider, a physician is going to be that really rolled up version that gets them to target what is needed for that patient and get to their tailored care most effectively.
Great, thank you. One more question here. Most SCOH is not impactable, according to the person who submitted, such as poverty, education, crimes, single parents, domestic violence. These can be easily removed and all need cultural, political, societal intervention, which is beyond healthcare. How do we respond to that?
Yeah, so that's I think really well said, and I think you have to take one step back and just recognize that while we can't change some of the individual attributes, and you've outlined a few of those there, what we can do is better align the resources around those barriers. And so, for example, if we know, and in our data sets, we wouldn't necessarily know about specific domestic violence, but we might know that the index of a particular neighborhood, the crime index of a particular neighborhood is fairly high. And so when we think about how we would deploy home health care services, we might make better or more selective choices about who and how many people we send into neighborhoods to effectuate certain programs or healthcare initiatives. But I think that's a great point. I think just understanding that these very serious issues are part of a person's life, they are inherently part of how we must consider how we will provide the best resources and ultimately the best care, even though we might not necessarily be able to directly impact or change one of these confounding factors.
Great, thank you. Well, very good. It looks like we have responded to all of the questions. Again, we want to thank everyone for their time this afternoon. Again, visit the Resource Center. You can also visit the LexisNexis website, Insights and Resources section. There are some additional assets there that you might find helpful, and you should be receiving an email within the next 24 hours with a link to the recording. Again, thank you, and have a great afternoon, everyone.